Good morning, everyone. I'll be presenting our study on pigmented OSSN. We have no financial disclosures. So this was a retrospective interventional study on 136 patients. The primary objectives were life salvage, regional lymph node involvement, local tumor control, and vision salvage. We also evaluated the risk factors for local tumor recurrence. Now, coming to the results, pigmented OSSN made up for 21% of all the OSSN patients that we saw over 13 years. The mean age was 46 years. Of those who were referred to us, 67% were referred as OSSN, while conjunctival nevus was the most common differential. There was a definite male predominance. 8 patients had bilateral lesions, and majority of them were living away from the coastal areas or high altitude. Although occupational, whether it was indoor or outdoor, there was an even distribution. The mean maximum diameter was 7 millimeter. Nearly 77% of the patients had lesion which was less than 4 clock hours, and 97% of them were situated within the palpebral aperture, with limbus and temporal bulbar conjunctiva making up for the bulk of it. On slit lamp evaluation, 68% were nodular. About half of them had a gelatinous component. Keratin was seen in 72% and RB stain was positive in 81%. Interestingly, associated conjunctival melanosis was seen in only 32%. So the primary treatment was decided on the basis of the morphological type, the extent, and the AJCC 8th edition. So for small and medium-sized lesions, majority of them were treated primarily with excision. But when it came to the diffuse lesions, a significant proportion were treated primarily with chemotherapy. Those with extensive scleral involvement or orbital extension were treated with primary extended enucleation or exentration. So excision biopsy was carried out following the oncosurgical principles of no-touch technique and 4 millimeter clinically clear margins with cryotherapy to the edge. Recurrence was seen in 10 patients. Xeroderma pigmentosa bilaterality, interpalpebral location, nodular lesion, and invasive carcinoma came out to be significant risk factors for recurrence. On multivariate analysis, however, only xeroderma pigmentosa was significant. On histopathology, 42% were invasive squamous neoplasia, and pigmentation was because of pigmented dendritic melanocytes, macrophages with pigments, and neoplastic squamous cells with pigment granules. So at a mean follow-up of 10 months, all the patients were alive and well. 2 of them with regional lymph node metastasis had received EBRT. Eye salvage was achieved in 88%, and local tumor control was achieved in 97% of these patients. Visual acuity of more than 20 by 200 was achieved in nearly 85% of the patients. To conclude, this is the largest series of pigmented ocular surface squamous neoplasia, and it is evident that it is not so rare in tropical countries. Associated conjunctival melanosis is not a prerequisite, and this must be differentiated from other pigmented conjunctival tumors with a more ominous prognosis like melanoma. And for this, the clinical features like keratin and RB staining, which is seen in OSSN, these are all helpful, although histopathology is confirmatory. Management, a local tumor control can be achieved in 97% with a low recurrence rate. Those with a high risk of recurrence should be followed up closely, and prophylactic treatment may be indicated. Thank you.
Thank you, Ritika, for nice presentation. A basic histogenesis question. How the pigmentation get deposited in squamous cell carcinoma? What is the histogenesis?
Yes, sir. So based on the histopathology, we found that the pigmentation was because of, one, there were dendritic melanocytes, then there was pigment containing macrophages, and even the neoplastic cells, they have pigment granules. So there are 2 theories to it. One is that the cells, they phagocytose the pigment granules. The other is that there may be a melanocytic origin to it.
Okay. See, if dendritic cell expression is there in histogenesis, we have to have a dendritic cell marker for that. Okay. Otherwise, other marker, melanae or HME45 may sometimes show pigmented changes, because these are all a change that has happened in the pigmented cells.
Yes, sir. Immunohistochemistry was done wherever there was a diagnostic dilemma. So with Melane as well as HMB S100 and HMB 45 was used.
Thank you.
Thank you, sir.
Ritika, I have two questions for you.
Yes, ma'am.
Apart from all the information that you've given, it's a very good collection, a good series. I just like you to let me know how many of them were primarily identified by you and treated. Were there cases which were referred after being managed earlier, and what percentage was it? Number one. And the
Yes.
second question is, or okay, maybe you can go ahead with that answer. Yeah, please go ahead, Ritika.
Ma'am, 25 of the patients, they had undergone some form of previous treatment before being referred to us. The remaining were primarily treated by us.
All right. The second question was, you said eye salvage was close to about 85%, if I'm not mistaken.
Yes, ma'am.
So what stage of it was it 85%? Would give us more light on the
Ma'am, I didn't understand that, sorry.
what you said 85% eye salvage.
Yes, ma'am.
In what stage was it 85%? You know, you had few cases where there was metastasis, there was
Oh, yes, ma'am. So, so even those with lymph node involvement, eye salvage. So in those two patients, eye salvage was achieved with excision, and I'm sorry. So there were primarily exentration and enucleation was done in 14 patients, and later in those with recurrence, there were 3 who in whom we had to either enucleate or exentrate for recurrence. So these were mainly the T3 and T4 cases.
yeah, Ritika, that that connectivity would give us more information, especially when you're having such a large series. So then when you make a presentation next,
Yes, ma'am.
probably you can add these information, which will be helpful for others to also follow.
Yes, ma'am.
Thank you, Vishwa madam. Thank you, Nitika. Next we call Dr. Reena. Yeah. Yeah.
This was a very interesting.
Anirban has a question. Anirban has a
May I ask my two questions as well?
Thank you, sir.
Okay, so one is that you had poor outcomes in 15% of patients, as ma'am had pointed out. So were these patients of xeroderma pigmentosa? What accounted for the poor this thing apart from tumor size?
So, sir, yes, sir. So of these, basically, of the 17 patients who we could not salvage the eye, 18, 14 of them required a primary exentration or enucleation. So they presented with massive scleral invasion or orbital involvement at the time of presentation itself. And the remaining 4, they later had a recurrence with orbital or extensive scleral involvement.
So how many of these patients who had a poor outcome have xeroderma pigmentosa?
Yeah, so of these, xeroderma pigmentosa was seen in 3 of them.
Only 3, okay.
Yes.
The other question, this is not related to your poster, sorry. The second question was, what is the difference in outcome for your pigmented OSSN versus the non-pigmented ones, the ones we see more often?
Yes, sir. So more or less, the although I have not shown it here, but it correlated with the non-pigmented one. There was not much difference in terms of whether it was the clinical presentation or the outcome. But based on whatever literature is available in our series, there was a significant amount which was invasive. Majority of the reported cases have been squamous cell, carcinoma in situ or dysplasia. But in our series, 42% had invasive carcinoma. So that was probably the one thing which was different.
Thank you, Mritika. We are running short of time.